Transplantation. So that's the topic for today. I'm going to review some type of grafts that are important. Some of the things may look familiar to you, and we did discuss that as part of physiology. And what I want you to take from today's lecture is just understand the same players, the same immune mechanism, but now directed towards another pathway. One of the commonest operations that you can see, cornea transplant, very commonly done. And why did I put it over there? It's not rejected. Cornea transplants are not rejected, and you can guess why is it not rejected. Why do you think it's not rejected? Sorry? No blood supply, correct? No lymphatic drainage. So that's what it is. Since cornea doesn't have a blood supply, lymphatic drainage, because you have to have those cells of immune system to go and identify and then go for tissue destruction. So that's pretty much correct answer. Okay. Now, keep in mind that I don't know, I'm overdoing it or whether I'm finding you guys paying any attention to it, that the drugs which are coming up for those of you who want to work in transplantation or want to work in cancer, there are drastic changes to such an extent that even an academician like myself is finding hard to teach the subject matter in a really beneficial way. So you can see from here, I'll just give you an example, and you don't need to remember, it's not in your notes, that's fine, that one of the modern techniques that we are trying to do is that we want to basically help a person having a cancer. So you can see there are cancer patients, and then we have different choices. So what we normally do is that we take the cells, immune cells out from the cancer patient, we call autologous, and treat them. Or we can take a tumor out of that person and then replace them with some other cells from the other donor we call allogeneic donors, okay, like a bone marrow transplant. Or what we can do is that we can take those cells from the patient, we call T-cell cloning, and then set up a system whereby we can infect those cells by a virus. And I'll explain that to you when I teach you virology, because virology actually goes hand in hand with cell biology, and it's going to be one of the most important subjects that I'm going to teach. So you can see from here that whatever is missing in those cells, and we find out that they are missing, we can engineer it back into their cells via viruses. I think that's much is good for you to know over here. So there is a very robust, precise mechanism. How do we do that? And it's very clever, very neat, and it's very interesting as well. So keep that in mind. And organ transplantation basically is pretty common. And I'm not going to spend much of a time, but you can look at this CBS news video where what they did was that September 7, 2003, they had to replace. So they pretty much operated on this girl and then transplanted heart and 2 lungs. So it's a big transplant. And it's pretty much like removing everything. And then they finally found out that there was a big problem. And you can see it may not seem to you a big problem, but the hospital admitted it, and they said they made a mistake. And they had given this girl donated organ with wrong blood type. Just because the blood type was not correct, that caused her immune system to reject 2 major organs, heart and lungs. So you can imagine each and every cell is important, and your immune system is going to fight that. because it would think that you are messing up the norm. That's the whole immune system is like. So once the immune system figures out that you are putting immune system under the stress, may it be, stress for exam, for example, or stress for a medical condition, that is going to stress your immune system. In this case, you're trying to put an organ into your body, right? One heart and two lungs. It's going to take at least 12, 24 hours of operation. And then you just make one mistake, and there you go. Also keep in mind that there are tons of patients on the waiting list. And it was 2008. I checked this morning the update results. I didn't get a chance to post it over here. It's more than 100,000 for kidneys. Unfortunately, kidney transplant is very common, and you can see numbers going up: liver, heart, lung, pancreas, so on and so forth. So these are some of the things that are there, and many of you may get a chance to work over there as a pharmacist, where you will look at the dosage form or effects or side effects of those drugs. Now, I just want to create a little bit of interest in you, that you will wonder what is going on in transplantation. Of course, you must have heard about blood groups, and that's rejected. And many a times we learn from normal physiology, because remember I said that we really need to keep update with what's going on in development in terms of immunology. And there's a simple question you ask yourself, and you come up with a new drug. And you must have heard from me or anybody else that it takes $1 billion and 10 years of research for drug companies to come up with a drug. So it's an enormous amount of money, enormous amount of effort. But all starts with a very simple question that you ask yourself. And it could be one of you. You never know. Don't think that you have to complete your degrees, you have to have a PhD or MD or PharmD to come up with a good idea. You can come up with a good idea at any time of your life. Just simple question. For example, there's a question that why is it the fetus is not rejected by the mother? Simple question. Pregnancy is an example where the genetic material, half of it is coming from father and the other half is coming from the mother. So technically, your system should reject it, correct? But normally it does not. So there is some protective mechanism. So we need to learn from that and apply it for our good use. That's why one of the most important field of advancement in immunology is reproductive immunology, because there is a very precise mechanism. And I can just give you a little bit of an idea that normally fetus is totally protected to such an extent the mother's immune cell will never see the cells of fetus. This is how well protected that is, right? But what may happen is that especially at birth, when the placenta is cut and there's a little bit of injury that may happen to endometrial lining of the uterus, there is a chance during the traumatic expulsion of placenta for some of the cells of the baby to pass over to mother. That's the basis of rhesus incompatibility, and that leads to a disease called erythroblastosis fetalis. But that wouldn't happen for the first pregnancy. It happened with the second pregnancy, especially if the fetus is Rh positive. Okay, but that's a good question you have to ask yourself, and that is one of the major research that's going on for transplantation people to figure out why is it the fetus is not rejected, and with a different genetic material. And there are many questions, there are many things in the mind of scientists, and you can see from here, this is a natural situation, so that's important is. And sometime, as I said over here, when placenta is cut from the baby, umbilical cord, so that trauma over here may allow some of the cells from the father, because mother cells are already known to mother's immune system, and that will basically lead to an antibody against paternal HLA class 1 and 2. Because By the end of the day, it is an MHC, which is HLA, and you mother will then make antibodies for HLA. So that's as simple as it could get. And what may happen is that that's an haplotype. We'll talk about that in a while. But I mean, just for a brainstorming or an idea-provoking thing, you just have to come up with an idea that I'm going to ask you as well. So what do you think is happening? What do you think, based upon whatever you've learned so far, why is it the fetus is not rejected by the mother? And I told you it's very protective environment, but still you need to explain in terms of scientific information. So does anybody want to make a guess? Tolerance. Tolerance basically, well, it's a phenomena, but I would rather want to know exactly what's going on. Yeah.
Does it have to do with how it leads to the mother, like it's getting nutrients from the mother?
Well, nutrients are provided via blood to the mother. Baby is getting nutrient, but the whole idea is that the umbilical cord is for to supply of nutrients. So nutrients are supplied, and blood goes over there. But what is it that protects? No, RH being present is going to be a problem. I'm talking about normal physiological mechanism. Just think, simple things, yeah. Yeah.
Originally when the mother gets pregnant and it starts out like in the fetus comes, it becomes adaptive immunity, like it gets used to it, or it doesn't.
Yeah, don't think for first time pregnancy, when the genetic material is coming from the father and the mother immune system is not seeing that. That's the whole idea. Let me help you. Well, you got it a little bit late, but you are right. Placenta is basically the major barrier. Placenta, such a big placenta, is a barrier there, and it is for a good reason that it filters that. Remember, to such an extent that we thought that there is an Fc receptor for IgG. So even if it's not going to allow IgG, which is protective, to pass to the fetus if there's no placenta. So placenta, of course, is a good barrier, right? And the other thing is it filters anti-MSC antibodies. So that's very interesting. Even if mother was to make antibodies against HLA, it will filter it. The other important thing is that you have to keep in mind trophoblast, which is the outermost layer of fetal tissue, is in direct contact with the maternal blood. So if you know the separation, we call it placental barrier. So there are layers of tissues over here, and blood comes over here, is kind of seeps into the system. So it goes through all those layers which are there. So these layers are important because there is no direct contact of the maternal blood with the tissues. And then again, they're all receptors there. They're all important sieves and barrier, which are, of course, known. I'm just giving you an upshot for that. And the other thing is trophoblast itself, which basically sees mother's cells. It has either weak or no MSC expression. What would that suggest to you if I tell you this information? That the trophoblast in placenta MSC expression is either absent or weak. There's no antigen presentation. Simple. If there is no MHC, there is no antigen presentation. If there is no antigen presentation, there is no activation of cell, nothing will happen. Because as a rule, you have to present an antigen on MSC for your immune system to see. Immune system is blind, especially the T cell. If is a weak presentation or absence of presentation, they will never see. If they never see, why would they respond? Does that make sense? Simple thing, think simple. There's no antigen presentation cell, because for antigen presentation cells, you need MSC class 1 or class 2. Correct? Okay, good. So you guys want to move forward because people who come closer, maybe they answer more questions. That's the research. Okay. Progesterone itself is immunosuppressive. That's a hormonal effect. Okay? And then again, placenta, there are many different mechanisms. I just picked up something. There are many different mechanisms over here. And the idea is that we know for sure that there is a protection. And now what we want to do is, but why are we interested in that? Why are we interested in knowing that why a fetus is not rejected by the mother? What is the interest here? A disease? There are 10 textbooks of diseases. You say a disease. Miscarriages. Immunodeficiency. Anybody want to guess? Why do we need to know that? Cancer. Like? Organ transplant. That's what the topic of today is. Organ transplant. We want to transplant an organ, and we don't want that organ transplant to be rejected like a fetus which is not rejected by the mother. I mean, that's the topic today. That's what we're interested in. Why we brought this thing in transplantation is that we need to study the mechanism by which a tissue, an organ, because the fetus itself is an organ being transplanted into mother's womb, and yet it's not rejected. So our idea is that we want to give you an organ and not let your system reject it. That make sense? Okay? Now, transplantation basically talks of MSC genes. That's what I said right a while ago. It also talks of many other things, and there are many other uses that we have. And also keep in mind that this MSC genes, what's the other name for MSC? HLA. Which one is correct for human beings? HLA, because it's present on human leukocyte antigen. It's on your lymphocytes. That's the important thing. The tissue typing. So this tissue typing, I don't know whether you're familiar with that, it's not an interest for transplantation alone. So if you want to donate the tissue, they will do tissue typing. Can you think of any other uses of tissue typing that we come across in our day-to-day life other than transplantation? Because you see, well, who cares? I'm not interested in organ donation or receiving an organ. I'm fit. What do you think are other possible uses for this type of okay, I don't want to storm your brain too much. We call forensic evidence. There are many uses, tons and tons of uses. For example, in a crime scene, for example, over here, you can see you pick up a particular tissue type of blood or tissue or cell or hair, you name it. They pick up one cell from there. Okay? And they will then have run for A, B, C, D suspect. All of them have MSC. All of them have HLA. So they carry genes, right? Guess what happens? So you have one specific over here, and who does it match to? Exactly. 100% confidence. So that's serious. That's why you must have heard day in and day out, all these prisoners are requesting for the forensic evidence, MSC, HLA typing, and all those rulings have been overturned because that is considered as a gold standard. So that's another important thing, forensic evidence, okay? To such an extent that if these people who run these labs, if they were to report it, I'm just going to give you a report. So you can see that presented in the court, right? You don't have to worry much. What you need to worry is that the index basically probability of is 99.99%. So this thing is called polymorphism. So we all regardless of how we are, who we are, we all have a different tissue type. We may have, same blood type, many of you A plus, B plus, but we cannot have the same tissue type. So if by chance any cell is left over, hair, blood, any secretion, a single cell is there, they can pretty much, you just need one cell, and they can expand it, and then can basically go from here. Okay, and you can see that they will take the blood, or there are many things, but the point I'm trying to give you, this is important. So forensic evidence, the other is parenting testing. Sometimes you are in a legal battle, and then you don't know. There's a disputed paternity, so they will run an HLA for all these people, a HLA for the baby, and you will figure out who's going to claim to be the parent. Okay? The other important thing, sometimes babies are lost, and then there's a claim over here. Again, that's very important. They will do the HLA typing and find the answer. I was reading that they had the exchange of babies. Sometimes the babies are born and they got exchanged. And you'll see it doesn't happen, it does happen. And sometimes they find out after 10 years, 15 years. But now, the thing is that all you need to do is that if such a couple is there, they had twins, and one of them got kind of replaced, and you can see they would do HLA typing and return the baby. Okay? So you can see there are quite a few things that are out there for us for a good use. So all they are based upon the idea of transplantation, MHC, HLA. Okay? So let me go through some of the basic concepts that you can kind of remember. Commonest one is blood transfusion. And the important thing for blood transfusion is that since RBCs, why do RBC not have a MSC antigen? Why do they not have an MSC antigen? Because they don't have a nucleus. Simple. Because as a rule, all cells having a nucleus have to. So we basically are dealing with a graft. And grafts can be skin graft and many other things. So let's see what happens, and the idea is that who's going to give the graft. So most of these experiments were, of course, done in mice, and these are some of the terms I really want you to understand, because you will hear it a lot when you go for transplantation labs and transplantation clinics and so on and so forth. So you can see if a donor and a recipient. Autograft means that we take part of your body and put it on you. So if you have a skin injury, skin burn, we take one of your part of the skin and put it on you. There should not be any rejection. Okay? Or what we can do is that we can have a isograft or syn graft where there is same MSC molecule, MSC8, MSC. Do you think that happens in human beings? Well, identical twins. Very good. That is the only, I would say, exception. So you can safely do that because they may have, but still there's a major antigens, but you can see they would take the graft. But if you have an MSC-A and MSC-B, and this is a donor recipient, graft will be rejected, though the species is the same. Okay? Now what you can do is that if you want to have a MSC across the species, like you want to give from mice to rabbit, of course, it's called xenograft. It will be rejected. Okay? Now, these are the terms you can, again, try to remember: autograft, isograft, allograft, and xenograft. That's what we previously mentioned. Now, the next question is why and how the graft gets rejected. The commonest graft done, I remember I was at Burn Center at Loyola Department of Surgery. There's a regional, and what they would do is that whenever a burn patient will come, So they will kind of scrape off the superficial skin altogether and replace their skin on top of that, called skin grafting. Right? A very common procedure done. And then they actually wait if that graft is taken or not. But if you were to look at that in terms of the sequence of events, so you can see immunological basis. Why is it the graft gets rejected? That's the question you want to ask yourself. So you can see this is an autograft acceptance, and this is the first set of rejection, and this is the second set of rejection. So keep in mind, when you take a tissue and put it in another tissue, I give you an example, you take heart and lung, and there were remaining blood tissue over here, and that blood tissue evoked an immune response to such an extent that killed the tissue. Okay? Now, one thing you have to understand that everything will take time, because once you have this grafted epidermis, right, over here as well, and then blood vessels will come, blood vessel will grow. This is another revascularization that happens in injury as well. Whenever you get a cut, there are cells which are specialists in terms of regeneration. So they will come and regrow blood vessels. Some of the cytokines are very important in that. We call revascularization, especially after myocardial infarction. If your heart tissue gets ischemic and it's dead, and you want to have a healing process, you want to introduce new vessels. So it's called revascularization. That's what it takes a while. So you can see revascularization happening over here in this graft. We get kind of mixes over here. And over here, you will see it is there, but not that. And then again, when the vessels come, the cells will come. Right. So vessels come, cells will come. And initially, cells, the first line of defense you can see is neutrophils. So neutrophils basically are okay. They will do healing, and they will repair and remove the debris. But if there is other cells other than neutrophils, for example, monocytes and other things, right, then there is a problem that your immune system will be activated, okay? And if you were to compare all these three, you will see, for example, over here, there's a full acceptance of graft. You see graft gets over here. There are little neutrophils there. What you will see is that immune system has not come over here. The cells of immune system have not seen that graft. They're okay with that. So that's one way we get a good graft or good organ donation. The other things that you can see is a full rejection, because the cells of immune system come over here and they look at this cell, they don't like it, they kill it, and then you have necrotic tissue and there's a full rejection over here. We don't want that to happen. We want this to happen, and that can only happen if your immune cells are not there. Okay? Now, in the third circumstance, what may happen is that not only this get rejected, but the information that immune cells picked up from this graft, they basically is stored in memory cells. So what will happen now? If you want to do it again, it will come back again. So there will be a rejection again, and that would not take that long of a time. That will be fast. Make sense? So this means we have a timeline. We have an acute rejection. We have a chronic rejection. So this is like a time limit. Now the question is that how do you stop that? Okay, simple question. Since we know that these are the immunological bases, because if you have lymphocytes, monocytes coming over here, they will initiate a delayed type hypersensitivity 4 reaction. That's the other important thing, remember, because of the CD4 involved, right? Now, if you remember, how do we know for sure that T cells are culprits? So in this case, T cells are the troublemakers. But you cannot survive without T cells. T cells are required as well for your normal immune response. How do we prove that? So once we have animals that don't have a T lymphocytes, and if you want to put a graft into them, they would never reject it because they don't have a T cell. So that is a scientific proof that T cells are the major players that are involved there. Correct? And then again, you can use immunosuppressive drugs like steroids, but the effect of steroids will either going to be slow or time limited. So basically, this will be one of our choices that we want to kind of downplay the whole immune system. We want to control all these players, okay? But when you do like a clinical classification, I just told you, hyperacute rejection, and we have acute rejection and chronic rejection. So these are the three important concepts that you have to understand. It will tell you and answer your question. The person got a kidney today, how long will it take for the body to reject it or accept it? Okay, now let's take one by one. Hyperacute rejection. If the transplant was done like today, in that case, when the heart transplant, to lung transplant, it was there and then. So it sometimes may take minutes or few hours. So that's a hyperacute rejection, very fast. What do you think would be the cause of that, based upon whatever I've just told you? Sorry? Memory cells. Well, I can assure you that to call memory cells and look at that is not going to take minutes and hours. Memories, when said T cell, they are slow. It takes a while. That's why it's called delayed type hypersensitive. You're talking about 24 hours or more. But in this case, I'm talking about few minutes or few hours. Sorry? Complement. Okay. What else? Some of you just said antibody. That is correct. Antibody, but which kind of antibodies? Preformed antibodies. Preformed antibodies. Remember, in the type 2 and type 3 hypersensitivity reaction, to make antibody takes long time. But if you have already I just told you that in pregnancy, after first pregnancy, when placenta is avulsed from endometrium, some of the cells may pass into mother's circulation, and mother may make some anti-HLA antibodies. So that antibodies are preformed. The moment you see an HLA again, they're going to go and destroy the tissue. So this is a typical situation that we have preformed antibodies. Okay? Then again, once you have a preformed antibody, you will have activation of complement, you will have platelets coming over here, you're going to have inflammation, you can have thrombosis, all those clotting mechanisms are going to be initiated before you go in necrosis. A typical story that you pretty much know. You study necrosis, right? Okay. So if I ask you, what kind of necrosis do you expect when a tissue goes through that inflammatory response? What type of necrosis do you expect? Yeah, she's reading ahead of you. So you just have to read the line. She's reading ahead of you. That's what she's doing. So it's in the next slide. So that also shows me how many of you actually have read it, or they know that many of the questions are coming from next slides. Fibrinoid necrosis. So these are some of the terms that we normally use. Okay, example for hyperacute rejection is a kidney transplant. You can see from here, pre-existing antibodies are there. You put a kidney, it's going to identify that, call in all the cells of inflammation and reject. Hyperacute rejection of a kidney there and then. The second part is acute rejection. In this case, non-sensitized recipient. It occurs within days, and sometimes, if you don't treat, what they normally do is that if they give you a donation of an organ, they also suppress your immune system. I'm going to talk about that. But remember, this is a T cell mediated, and T cell directly recognize the alloantigen expressed by the donor cell. And very commonly seen when you want to give an organ and don't have a complementary immunosuppressive drug regimen. So you have to give the organ, then you have to make sure that you suppress the immune system so immune system doesn't see what is there, or it's a delayed response. Okay? I'm sorry? Non-sensitized mean because there's no preformed antibodies. Sensitized had preformed antibodies because it has seen that before. So that's what non-sensitized means. So typically what we discussed earlier, pretty much the same thing. Chronic rejection comes, because this is going to be a question. I'm going to ask you what are the causes of hyperacute rejection. I'm going to ask you what is the causes of acute rejection and how would you compare three types. So you can see from chronic rejection, it is both antibody and cell-mediated immunity. And it comes later. So don't think that you just transplanting a kidney and it lasted a year, everything is okay. It's not okay. You may reject an organ at the later part when they may have been performing normally. Okay? And that's a typical for renal allograft. So you have a renal allograft, that's what you see. The other important thing that keep in mind is that once we put a kidney in a person, transplant a kidney, we want to make sure that we are looking at serum creatinine levels. So they look at the performance of the kidney because once the kidney function got deteriorating, the serum creatinine level fall or rise. We did kidneys, right? Kind of. Rise. Serum, this is a basic test for kidney function test. Basic test. Creatinine level rises because the kidney is not functioning. Simple as that. Okay, and then again you have changes that you normally see. Okay, so I think you must have by now realized that MSC is very important, and these are some of the things that you have to keep in mind. That these MSC are cell. This is a repetitive slide. Basically, we already discussed when we were talking about the MSC. So let me give you two important concepts to remember and try to get that from today's lecture. What is the mechanism? How would T cell recognize the grafted tissue? There are two prevalent mechanisms, and they're all different. Just try to understand. One we call direct recognition, the other one we'll call indirect recognition. So in this case, also remember the keyword donor and recipient. Keep that in your mind, donor and recipient. So in this case, this is a host T cell, meaning recipient, right? And this person has been given, let's say, a kidney, and that tissue has a donor APC. So in this case, there is a donor APC presenting a peptide to T cell. So what would T cell say to it? Say it again. Say it louder. Yeah, reject it. He's not going to, because it will consider that as a foreign. It doesn't like it, but it is how it's presented to it. One way of presentation. The other way of presentation is that you have, in this case, a recipient APC, your own APC, picking up a portion of the tissue and processing it, and then presenting the same protein on your own MSC. In this case, MSC plus the antigen presenting cell was from donor. In this case, antigen presenting cell is from host. The difference is the protein it is presenting is still foreign. Does that make sense? Okay. And then again, you can see direct versus indirect. So that's a major concept you have to have, and I think you're smart enough to pick that out. The idea is that in both ways, T cell will see it, whether it's presented by the donor cell or presented by the recipient cell, right? But the point we're trying to make from this is that if it is a direct presentation, we are going to have acute rejection of the graft, right? If it's an indirect recognition, we may have tissue damage and fibrosis, right? But the result of this one is that this one immediately will call T cell destruction. And in this one, what happens is that you may develop cytotoxic alloantibodies. So the second one may allow for you to come up with antibodies as well. Remember when I say in the chronic rejection, there were the role of both cell and antibody, right? So have to make a chart, acute, hyperacute, acute, and chronic, and what are the cells involved. Now also remember, based upon your T cell activation, the T cell will activate under the influence of cytokines because we want to come up with drugs, right? So once, let's say, your CD4 T cells are there, so they will synthesize bunch of cytokines. So these are cytokines that they are there, and each one of them has a pretty defined function, and by now I think you pretty much know. But one thing I would try to explain to you for this slide is that if you have this interferon and TNF series of cytokine, it is going to increase expression of class 1 molecules. Remember, as I said earlier, if they're in trophoblasts, for example, I gave you an example, one of the reasons that the mother is not responding to the tissue is because either there's an absence or no presence of MSC. But if you have the cytokines in the circulation, you may get higher expression of MSC. So this would suggest to you, if I was to come up with a drug that I want to enhance expression, I will give you cytokines. If I want to down-regulate the expression, what should I give? Anti-cytokines, because I want to lower that, okay? And this is pretty familiar to you, but let me give you the overall holistic approach that will give you idea as to, let's say the T cells have recognized, and now there's nothing you can do. What do we do now? What are the options available? So if you were to draw, based upon your existing knowledge of T cell activation, if you were to draw a chart and start from the antigen presenting cell talking to a naive T cell, and this naive T cell has just come out of the bone marrow and it doesn't know anything. So we have at least four different type of options with 3 different type of results. Okay, and each one of them is based upon your existing knowledge, except that we are applying it over here. For example, if this CD4 T cell starts producing IL-2 and IL-12, so this will call differentiation to Th1 type of cells. And Th1 type of cells are pro-inflammatory. So the biggest cytokine that will come in pro-inflammatory cascade is gamma interferon. And gamma interferon will then cause higher expression of MSC class 1. So this is how kind of a cascade goes on. Okay? And then the more you present MSC, the more the foreign tissue is going to get rejected. Correct? Because the pregnancy model told us lesser or absent MSC cause survival. But in this case, the other way around. Correct? Now, the other choice is that instead of producing IL-2, it does produce IL-2 because IL-2 will be required for, it's a growth factor. So regardless of whatever you clone make. But if you start making IL-4, they will have Th2. Th2 will produce IL-5. And that day we found out that IL-5 also will call in eosinophils. And eosinophils are like mast cells with all those mediators coming in there. And they will come and they will infiltrate the tissue and reject the tissue. Number 2.
So you might ask, what, because Th1, Th2,
Say it again?
Th1, Treg, all of them are considered cytokines, right?
These are cells.
They're the T cells.
Yeah.
So what okay.
These cells are called Th1 cells because they produce a certain set of cytokines. Now, these cytokines can be released by them, or they can act on them as well in a autocrine way, right? So the other thing is that if CD4 decides to produce TGF beta and IL-23, especially IL-6, is going to form Th17. So Th17 will release IL-17, and then you will have neutrophilic rejection. So what you would do is that you just transplanted a tissue, take it out, and cut it and do biopsy, and you see all these different cells infiltrated into that tissue. Or you have a T regulatory cells, which is TGF beta, and that basically will also kind of put a stop to all these. But again, we'll talk about that in a while. The whole idea is, after this chart, we can go and stop all those arrows and come up with the drugs. Okay, for example, if I was to stop the lymphocyte from expressing genes for those particular cytokines, so I will use inhibitors for lymphocyte gene expression. And the drugs in the market are corticosteroids, normally what you use, steroids. Cyclosporin comes as a Neural, or FK506. So these are some of the drugs that we give when we give. If you want to inhibit cytokine signal transduction, you remember the primary signal and the secondary signal, right? Then we have to give anti-CD25, rapamycin, and leflunomide. So these are drugs that, and I'll explain to you where and how they act. Or you can, let's say the message goes into the nucleus, you can still stop the nucleotide synthesis by these sets of drugs. And these drugs basically will cause immunosuppression, whether you use them in cancer or you use them in other way. Okay? But what I'm trying to impress upon you is, and this one, for example, you know for sure antigen-presenting cell is going to talk to a T cell first signal, co-stimulation, second signal, which is a B7 and CD28, and then you have intracellular pathway. It's going to release those transcription factors, and then those cytokines are released into the circulation, and then they will have a desired effect. So when we develop the drugs and we use the drugs, for example, we can use a CTLA4 antibody over here, or we can use these two drugs to block the transcription process, or we can use anti-CD25 over here, so block the cytokine, and then there are many other drugs. You can see the more familiar are we with the intracellular pathways, the more easier for us to remember where and how the drugs are acting. Okay, I mean, for this class, I don't want you to remember all the drugs, but eventually, I'm pretty sure you will need to do that. So let me give you one last slide for in the last 1 minute before we finish. And some of them are pretty much the same that you can read on your own. Nothing special. Okay. Okay. I think I may have one last slide for you. Okay. Now again, I'm sorry if it's not very clear, but pretty much gives you the same picture that I showed you earlier. So you need to know for sure that the objective of getting a good transplantation is that you need to stop activation of T cell. Okay? So once an APC talks to a T cell, you can either block this signal over here, which is a primary signal, or you can block this co-stimulation. Remember I said B7 and CD28? And when CD28 is there, when does the CTLA4 come into the picture? When the cell gets activated, right? So you can block that. So you can block the activation of cell by giving an antibody for CTLA4. Okay? Or you can also block the activation factor for the transcription factors over here. Or you can block the, what is CD25? Sorry? No, T regulatory cell also present, you're right, but what exactly is CD25? CD25 basically is the name of IL-2 receptor. So once you have an, because remember, one of the things you want to stop proliferation of T cell is to block that cytokine where IL-2 acts. to basically stop the growth factor. So you can block that over here, and then there will be no replication of cell. So these are some of the choices that we have in terms of answering those questions which are there for transplantation. Okay? So I'll finish here, and if